So I just want to introduce our panel. I'm afraid I won't introduce you again, Chris, because you've already been inducted.
Here's Chris.
So Frances King is a registered nurse and the equity lead for Health Navigator Charitable Trust, as well as being the manager for Woven, the Whānau Ora Voices of Experience Network. She has a background in research and has held leadership roles across a range of health services, health settings and iwi-led health services. Mike O'Sullivan is the Deputy Director of Pūnaha Matatini, a complex systems research centre, and he's an Associate Professor in Engineering Science at the University of Auckland. He has contributed to research on resilience and wellbeing, complex health systems and healthcare delivery. Denise Astill is the Executive Officer for Foetal Anti-Convulsant Syndrome New Zealand. She's contributed to international research, publishing with international academics in their manuscripts, work to include fetal anticonvulsant syndrome in ICD-11, which is huge, and changes to warnings on epilepsy medication. Okay, so I thought we'd have a discussion today just about pretty much what we've talked about a little bit already, about how we can all work together as researchers, academics, clinicians, people who design services or interventions, and community groups to make some changes in care for people. And we've assembled a panel that some people have expertise in rare disorders and some people have expertise in that community engagement. So Mike, I thought I'd start with you. Yep. What community groups have you engaged with and for what type of research?
Yeah, depends a little bit what you mean by community. I go quite broad in my definition. So I would say I've actually engaged with clinicians from spinal muscular atrophy, such as Miriam and Richard Roxburgh, and doing some pathway analysis, a little bit looking at the effect of having an SMA child on parents' life pathways, and a lot of that was inspired by some of the stuff I saw through Compass and Barry and his team there. I work a little bit with Health New Zealand clinicians in surgical scheduling and looking to try and improve our waiting lists, so I kind of consider that a community. And then I'm working also with communities in Tairāwhiti and Wairoa around flood modelling and wellbeing more generally. And my own, former community, because I moved to Swanson, but I was working in my community in Te Aratū Peninsula, particularly around an idea that I call digital ecosystems, which is sort of making modelling accessible to communities so citizen scientists can contribute and you kind of get engagement and hope that people make a difference. So quite a different range of communities with a bit of research and engagement and outreach kind of across those projects.
And passing on to Denise. Denise, what researchers have you engaged with and for what type of research?
Yes, so I've made contacts with researchers both here in New Zealand and internationally. So I think it all starts with actually finding that connection. And having those conversations as to where the research is going to lead. And if I look at the research from, the New Zealand one, it was through a conversation at the Otago Dental School that actually led to research being done obviously for the teeth and everything, and for fetal anticonvulsant syndrome. So something that was very limited in research worldwide. So that's why the conversations come into place. But if I look about internationally, it's predominantly we've been working with UK, but also Australia. And again, the research all has come organically, and it's through those connections. So I could sit here and list you what papers have actually been achieved and everything, but it's through conversations that have driven what the research project is actually going to be about.
Frances, if you can unmute and just tell us about kind of your engagement work. What community groups have you engaged with at Health Navigator and for what type of projects?
So Kim engaging with community groups has been wide and varied over my working career, but I guess the most recent one has been doing some work for self-management support with long-term health conditions, doing a review for Te Whatu Ora, which included kind of looking at the national and international literature around that, but also meeting with community groups from the top of the North Island to the bottom of the South Island. Those groups were wide and varied, so from secondary care through to primary care, through to non-government organisations and community groups, and then specific groups like men's groups, those sorts of things, and also community groups, community-led groups that were volunteers. So quite a range of groups, and that throughout that process then looked at what was working well, what wasn't working well, and what sort of recommendations to make changes in the self-management support arena. And I might pick up on some of those a bit later on.
Thanks very much, Frances. And Chris, I mean, you've said that you had many more researchers join the research network than you thought. What researchers are seeking you out for engagement, and what type of research? That's probably a lot to sum up in, and you probably told us a fair amount, but maybe if you've got a...
Yeah, and I'm probably not even going to answer the question directly. Angela says when I'm talking to the media that I should come prepared with a key message. So I'll kind of answer the question and I'll seg into another message after that. Difficult to answer because there's so many different rare disorders researchers doing so much different work. So what we tend to hear about is a little bit random and tends to depend on the researchers who are putting in applications who specifically need the support of Rare Disorders New Zealand in order to reach out to a particular patient group, and can we help them do that and point them in right directions. Essentially if they do that, we're happy to help, and we say to them, but that involvement needs to be valued monetarily in your research grant. So it hasn't really materialised much to date because a lot of those research proposals haven't yet been successful, but it is one potential source of revenue for us. So that answers the question pretty generally. But I think another key question, and maybe we'll come on to it later, is how we incorporate that community and consumer engagement. And it was always part of the vision that we would do that way back when Karen put in her original activation grant proposal. And it's probably fair to say that we haven't quite got that right yet. But if you reflect back on that photo of the meeting that we had in December, you'll see that Kim McGuinness was there. She's Rare Disorders New Zealand's relationship manager, and she was specifically there because of that role, because she's the kind of conduit between RDNZ's activities and our about 150 different rare disorder support group leads. So it was kind of sending a message that yes, we need to work on that. Kim was there in the first instance, and I think it's also worth reflecting on the fact that when I was in Bulgaria last week, I noticed that a lot of the national merit groups had their beginnings in academia or research institutions, and a lot of them were having discussions about, well, how can we engage with our national umbrella groups. There wasn't that many of us, and New Zealand was one of the few exceptions where we were able to say, well, we're not having that conversation because the National Support and Advocacy Group actually initiated our initiative to become a national merit group. So even though it might look as though we're not, where we we're not where we should be clearly, but internationally we're not doing too badly, which is I think is a good thing. But what it does is causes us to reflect on we need to do better. And I said that we are going through the process of reviewing our terms of reference for this newly named and created group. So that will give an opportunity to rethink that, and we're also going to review the membership of that group. So that gives us an opportunity to rethink that, what we want that consumer input to look like as well. So a work in progress, and these are just insights that we've been coming to over the last 2 or 3 months.
But it kind of leads on to my next question for you, Chris, which is going to be what can we learn from some of the international collaborations? So obviously there will be groups within ADERA that have been doing, we've just we've just set up this national mirror group. They will have been doing that for a lot longer. Is it that they haven't really been doing community engagement, or have they got guidelines in place that we can use, or is there anything going on in that space?
So just to address the last part of the question, I actually think that we're kind of the exemplar, one of the exemplars within ADERA in terms of that community engagement, just because it was the Rare Disorders New Zealand as that national umbrella group that initiated our becoming a national mirror group. So I think we can take credit for that. And the other thing that where we can take credit is that we deliberately made a commitment to the Treaty of Waitangi and engaging with tangata whenua right from the get-go as we establish our national mirror group, and that is pretty unique. So they're two positives. So it makes us feel as though we're not an absolute minnow in the total world of rare disorders research and national mirror groups. Having said all of that, most countries are well advanced of New Zealand in terms of all of the rest of the infrastructure and support that they have from their government, and the support that they have from the implementation of their equivalents to our rare disorders strategy. They also have the benefit of integrating rare disorders research with what are called ERNs, their European reference networks, based around clinical specialty groupings that then pick up the particular challenge of supporting with people with rare disorders in those clinical groups. We don't have anything like that. We're on the verge of establishing a kind of a national one of those, which is being called a clinical reference group. Te Wharaora is working on that right now. So we've got a lot of work to do, a lot of catching up to do, and a lot of learning from the European colleagues.
And Mike, I was wondering, as a kind of engagement expert, are there particular methods of doing research or frameworks for collaborative research that you have found particularly useful?
In our work, when we're working with communities, we sort of stopped and reflected a little bit, and actually some of the decolonising methodologies are really important. Show up, use your ears first. We don't go bring our expertise looking to use it, we go looking to find out what are the issues the community needs help with, and if we're the right people to help, then we can talk about that, and if we're not, being from a university, being in the research space, we might be able to point them in the right direction. And so I think it's really showing up and a little bit caring, probably, and following up as well. So I think there's, and some of the other work I'm doing on educational pathways, I think there's nothing worse than showing up and giving people hope and then disappearing a little bit. And I feel a little bit like that's what I did with the SMA, if I'm being honest, Miriam. So, yeah. Okay. I'm glad you don't, because, I mean, there's also, one of the things I'm terrible at is I just say yes to everything because it all sounds great, and then you end up overloaded. So I think it's not over-promising as well, because I think then you can break the trust, and that means the next person who comes along has less of a chance. And finding champions is really important. And so I think there was some discussion on champions today, and also sort of having, so I think both Miriam and Claire talked about a little bit, frameworks for how do we progress from this initial discussion about what the issues are and what we might do together to, and if that works well, then do we have a way to then move it towards a cool engagement and a proof of concept or a prototype research project to something that has a bit of legs. And always, I think that in the initial conversations, I don't really like to talk funding, but it is an important thing to find out of how, if this goes well, are the avenues to do that. And within Te Pūnaha Matatini, we're a bit lucky we have some seed funding, so we can sometimes use that to start some work with projects, and probably in Tairāwhiti. That was what happened in Wairoa. Had an amazing person there, Joyce Campbell, who's in fine arts at Auckland, from Wairoa, and she just heard that I did some useful flood modelling stuff and then hooked me in. So I think those connections, I think what Miriam said around showing up to things like this and talking to people and just building those connections. I think, being open, showing up, listening, food's always good. So, and also, when I start projects, my philosophy is no one should work for free, except for me, it seems to turn out. So even with some workshops we've done where people have given up, a couple of days of their time, we've tried to give them a koha, although I don't think I'm allowed to call it that within the university system. But so I think valuing people as well is really important. I mean, we're all busy and we're all time poor. So if someone makes time to come and talk to you about stuff, just make sure you value them, and that might be providing coffee, donuts, a beautiful lunch like today, or maybe something to help cover their costs, I think. Yeah.
Denise, we've spoken before, you've spoken very highly of some of the international researchers you've worked with. So perhaps not just focusing on those, but when you have worked with researchers, what have they really done that has led to kind of positive experiences for you and for your organisation, and having your voice really feel valued? Are there any standout kind of examples you can think of?
Absolutely. So if I think about the positive experiences, I think about actually implementing our questions into research, because we're the ones who are living it 24/7, and so we know what we need to have researched. And so we're the why, and so remembering we're at the heart of your research and valuing us and bringing us in from the inception. Before you even go, right, I've got money for research or something, it's like, no, actually, what do we need? What do you want to know? And then actually you're part of around the table. So you're collaborating with this researcher or researchers the whole time. And so your voice is valued. And because, this has happened for me, particularly with the UK international researchers I've worked with. Certainly we've been paid as well for our knowledge, and that hasn't happened before actually. And also as a collaborator, being acknowledged as a co-author. So having your name on a research paper that you've been part of, it goes a long way, because it acknowledges how important you have been to this research. And also, further research. So what we have actually found with working with particular researchers over in the UK is, because they've got so passionate about particular topics, they actually then want to do further research with you. And so they want to include you again from the inception while they're just still discussing about it. And then putting in practical ideas. Okay, so if you've asked for something, whatever the research might be, and it might be guidelines or whatever for healthcare professionals, now they're going to design something that you can hand to healthcare professionals, that you can email healthcare professionals. It's not just a research paper that's collecting dust, it's a practical document that you can actually use. And I just think it's so good because they've also been putting it in language that everybody can understand, which also includes tables or pictures or graphs, whatever it might be, but it's in an accessible, inclusive way.
Thank you. I feel like we do. I know more I look at was looking into who was coming to this event and everything, more I realise how many of members of the support group have been included in publications. I feel like we need a little library of our own publications to, say this is what collectively we've done as organisations. And Francis, just question to do with you about how you establish relationships with community groups from the beginning of a project, and how do you sort of sustain that throughout a project?
Yes, I think many of the points have already been mentioned, but I guess one of the things is, start with listening. It's not about the project. You're meeting with people on their own turf and you're asking them what matters to them, and you're listening to their why that sits behind their priorities. So really reinforce that. I think looking at existing who's in your group, who are the champions, who are the people that are respected from that community, and working with them, beginning with small and practical. I've already heard these words coming through, low risk, concrete things that can be done, that can be achieved, is a good way to set off. And then showing up consistently, following through. If you're saying you're going to do something, do it, that's what builds trust. So it is very much about building relationships, building trust, being listening, and valuing different kinds of expertise, valuing the cultural inputs that you're getting, valuing the lived experience that you're getting. So everyone is part of the journey. Absolutely agree with building it from the beginning, not going in halfway after a little group has decided this is what's important. So yeah, and longer term, once you've built those trusted relationships, they continue way on beyond the life of a so-called research project or that sort of thing. So that's kind of my take on it.
Thanks, Francis. And I wonder about if you could kind of say what some of the key barriers to engagement can be. And I was just thinking while you were talking that, sometimes, and especially in the rare disorder space, we've got a lot of people to try and include in research when we're thinking about a broad project. How do we make sure that everyone's voices are heard?
If you think about barriers, on whether they're structural barriers or relationship barriers or communication barriers, there's lots of, or practical barriers. So, like when you're planning meetings, what's the time that suits your community? Are there issues around childcare, transport, venues, all that sort of thing? Thinking about relationships, and certainly in the area that I come from, which is high Māori population, very rural, there's a lot of mistrust in institutions. So being able to recognise that or listen for that and understand that, and then put measures in place so that you're able to overcome the barriers.
And yeah, same question for you, Mike. What are the common kind of barriers that you find are in place when you're trying to establish those communications?
I think like the initial connection is really important, like who you connected to and what barriers are there to talking to people. Then I think human resource barriers often. Again, I was talking about being time poor, and so having someone who can take it on, own it, and I think students are really useful there, but they've also got their own imperatives that they come with, I guess. So I think when I think about the things that have helped with those communications is having the champions. I completely agree with what Francis said. So we usually meet with the community in Makarika, which is about an hour and a half plus a little bit drive from Gisborne, and so we just show up and then they can come to the local marae and we can talk to them there rather than try to get them all to Gisborne or Auckland or something like that. And so I think that's really important. A little bit of money is useful. So I've been lucky enough to have a little bit in my research account that I can use again to show up, but also to bring some resources to those communities in those proof of concept or original prototype studies. So I think being able to give a little in to show that you're really invested can help break down some of those barriers. And so if you don't have people, you don't have a little bit of funding, it just means you can show up and have a bit of a korero and then you disappear off again, and I don't think that's especially useful. Yeah.
And Denise, what do you wish that researchers knew about engaging with your community, or perhaps engaging with the wider community?
We're a wealth of knowledge. I mean, I'm
true.
going to probably echo a lot of what Francis has actually just said. Like I said before, we're living at 24/7, and so the sort of knowledge that we bring isn't found in books. It's a whole new level, I'd have to say. And I always go on about being an expert by experience. And, and for some people that's a lived experience, some it's an expert by experience, but I don't think people really value what we have as much as they should. And like I said before, we are the why. If you're ever wondering, and just come and listen to one of our stories, and you will know why we are so passionate and why you should get motivated about why you're engaging with us and what you can do. You're there for, helping us really. It's not the other way around, because if we're being completely honest, we're struggling in rare disorders. It's not easy, and it's like you're fighting the system all the time, and there is a lot of trust that is gone from the health system right through to disability. We're sometimes coming in with a chip on our shoulder, so approach us with respect and, be honest, transparent, caring. You don't know what has happened that day, and it might be that we have to cancel last minute because all of a sudden something has happened, rare disorder wise, and it's like we've had to go home, we've had to go to the hospital, we've had to do whatever. So as much as we want to be part of the research, and like we 100% do, there might be a reason why we're not turning up that day, and it's not through lack of the wanting or commitment, it's just that we simply can't. Also, Francis began on this as well. She was talking a bit about this accessibility, and because that might look different for each person, because it might be that actually, I need easy read papers, or I need to have an accessible toilet, whatever it might be. I might need to have a quiet room. So if I'm having a meeting with you, or anything, I know that, okay, they know what my requirements are, and they're going to honour and respect that without sort of looking judgely at me. Yeah,
I found that really really important because, you know, I've been saying to people, well, can I meet with you? And there's lots of people who aren't able to meet online or aren't able to meet in person. And so it's about offering those, you know, do you want to talk on the phone? Shall I come to you? Do you want to talk online? I think mostly you just offer people options and go with whatever they suggest. Chris, what do you see as some of the key barriers to kind of really getting the collaborations and things moving between all the different areas within Rare Disorders New Zealand so that we can, you know, all work together to affect change?
One of the key barriers is really reflected in the question, and that is that when it comes to rare disorders research, we haven't been particularly well kind of stitched up in the sense of being joined up. And I think that's what we're trying to do with this network initiative, is try to improve that. So you look back 3 years, most rare disorders researchers in New Zealand didn't really know of each other's existence, even though they would have been well connected and quite well respected internationally often, just not known in their own country. So that's a first start. And then the second challenge is the one that we've been speaking about today, is how do we then connect the actual research community, who do we identify as being part of the research community, and make those connections with the different consumer and support groups so that they feel that they're being heard and engaged with.
I think there's probably a lot more crossover than we do realise, and that's because there's a lot of people who are members of the research network who also have a role or volunteer for an organisation. I think probably if we did I love a Venn diagram. If we did a Venn diagram, and the same with clinicians, you know, there's lots of overlap. And I would say to researchers, especially students, not everybody has the time, but if you are, if students are doing research and they want to, know more, then see if you can volunteer for a support group, and you might end up on the committee for 10 years. Is there any questions anybody would like to ask the panel or would like to discuss?
At the moment, we don't have anything like a rare disorders research platform, and we've got nothing on the immediate horizon which gives us any hope over the next maybe couple of years that there will be one, and that is in contrast to a lot of countries in Europe who have actually got a specific rare disorders research platform in their country. One of the problems we've got at the moment is we don't even have a health research platform to speak of, let alone rare disorders. And part of the reason for that is we're going through a big change in terms of our science system, and that hasn't settled down yet. There's big questions about the future of the Health Research Council and whether that will be disestablished and be part of a new health research funding mechanism. So it's really difficult to see how that's all going to play out. But from the point of Rare Disorders New Zealand and probably the new National Mirror Group with its new name, is that we will be pushing for that. Because for rare disorders research, it's really important that research gets a fair share, even an unfair share, of the funding that's available, and having a rare disorders research platform would be part of that. Working on that, but there's a long journey to go before we achieve that, I think, as things look at the moment.
I think because there is a DNA platform, research platform. I think it's more on disease spread, but I wonder if you can leverage that, because I suspect the government won't want to do a full rare disorders one, but they might be able to sneak in the side. So I could bang something. So, and then I guess my other response is actually, I think every rare disorder community actually is an opportunity for researchers. You've got to, I think you were sort of talking about that, and from a slightly different perspective of data science, AI, my feeling is every time data is used for research, you've got to give some benefit back to that community first, and everything else comes after that. So when you were talking about accessible documents, even if you don't get a conference publication, journal publication, but provide something back to the community that's useful, that's a win for me. And I think that's requires a bit of a change in mindset of some researchers. But I think if communities realise actually they're valuable, and I think New Zealand in of itself for health systems, for the stuff I do, is an incredibly valuable test bed for stuff that overseas countries are really interested in. So there's stuff we can do here because of our size, because we're a reasonably centralised health system, that I think it's really useful for other countries to have a look at. So Chris, I'm back to you.
When you mentioned the RNA platform, I just wanted to acknowledge that, we do have an RNA platform in New Zealand. That was originally set up as, and still is, as a mechanism for providing insurance in the future for future pandemics and making sure that we had the ability to be self-sufficient when it came to the manufacture of vaccines rather than relying on the mercy of overseas suppliers. But as it happens, that platform is really useful for some forms of rare disorders research. And there are a very small number of very, very clever scientists in New Zealand who are using that platform to develop new therapies for rare disorders. But it's part of the solution, but it's not a whole part of the solution.
Thanks, Chris.
Maybe a starting point, you can start expanding.
I just wanted to backtrack a little bit on what Deborah referred to. So just a kind of a definition of what you mean is a research platform.
I can give part of the response to that, and one of the visions that that Rare Disorders New Zealand has had as we embarked on this capacity building journey with respect to rare disorders research is that we would be able to showcase what research is going on, and that would be a portal, I guess, or a source of information for individuals who might be interested in that particular research. It's a big job, and it goes back to what I was saying before. We're not currently resourced to do what our obligations are, just in terms of setting up a national mirror group, let alone anything else. So yes, it's on the long-term agenda, and it's something we'd like to do. And if somebody else wanted to do it, that would be great.
But effective research happening in a way that would draw more research, wouldn't it? Ideally, perhaps. Thank you.
Actually, I could just step in and make one additional comment in response to your question. I did show my last slide, and but something that I had on there was how in the neurogenetic world we're trying very hard to grow our PIs, our principal investigators. We can't have a clinical trial without a principal investigator. And ideally, your principal investigator is a clinician who works with you or with your patient group very closely, knows the patients well, and cares, really cares. And it's important to partner with these people, find out what do they need to be a PI, and together you get there. So that was in response to that. We need PIs, we need specialists, we need to have, and along with the PIs, the number of other people involved in clinical trials is just tremendous, and we need more study coordinators and evaluators and all of these things, very important. I wanted to ask a question about patient advocacy training. So I recently attended the Treaty MD meeting in Europe. It was an amazing conference, and every single session included patient advocates, and all of them talked one way or another. These were all highly trained people, and Denise, you might be able to speak to this best. I don't know if this kind of training exists here in New Zealand or could be accessed from overseas. I feel we need something kind of specific to our context, we're different from the US or Europe or wherever, and we do need this training as well. So could you make a comment about that?
Yeah, absolutely, I can. As far as I know, there is no training. However, there is generally someone who has been affected by the particular syndrome or disorder or disease that is really passionate and won't give up. And they are getting then sort of upskilling themselves in different areas, whether it be around a convention for disabled people or whatever it might be. I mean, to be honest, I had no background. I am a teacher by trade. And so when my girls got diagnosed and the only support was in the UK, it's like, okay, what am I going to do? So there's no formal training. I mean, I think what it does is you get the knowledge throughout the years of actually fighting the hard fight and just putting in your everything. And I agree, there should be training, 100%. Yeah.
So we've got an international New Zealanders advocacy training, but as you say, it's not tailored to the New Zealand market. Every time I see they might talk to advocacy or try to understand accessibility or anything like that, I try and sign up. And I know TICO have got accessibility training, and it kind of also encompasses community CRPD sometimes. So they speak to the patients and how they can advocate for themselves. So there are, every now and then there are small pop-up things that come out for sort of advocacy. But yeah, as to be said, we very much need that. I mean, I'd be quite happy to champion something like that if I had enough energy and I didn't have all this time for it, but yeah. Many rare disorders, there are few in number, and with our particular cohort, this is just an example, but I would be asking the question anyway. So we had fewer than 100 people in our we'd identified the prevalence. We knew there were fewer than 100 people with spinal muscular atrophy in New Zealand. And we wanted to get all of this amazing information from the IDI. We thought we were just going to be in for a treat and would be able to answer almost every question about SMA. And then we ran into that problem, didn't we, around how the number was so small. And I wondered, so it was too small for the IDI to let us have this information, and I wonder if this is something that has been addressed, because that was a few years ago. Has the IDI said something different now, or how does it work with using the IDI to do research into rare disorders where the patient number is less than 100?
Yeah, it hasn't changed, and I don't think it should change, and I've imposed extra confidentiality kind of clauses on myself about what numbers I will export. So when you use the IDI, you shouldn't be putting out a number if it's less than, so a number of people if it's less than 6. So I don't think there's a way around it. I think the only way around it is look at a broader set of conditions overall, which is what I'm doing, what Sarah will be doing to kind of there's some conditions that have similarities. I mean, you could do some sophisticated analysis within the IDI and still get the data out if you're count.
I would tend to say that the IDI is great for lots of things, but for really small populations, because of the statistical disclosure rules that you have to follow, it doesn't work particularly well. So for understanding a population of 1,000, it's probably okay. For understanding a population of 100, once you split that out by region and other things, you run into not just low number issues, but because there's a thing called random rounding, so any number gets rounded either up or down to a number divisible by 3. When you've got really small numbers, that really affects your estimates of proportions. So I just don't think, for really small populations, the IDI is the right vehicle to do that research. And Stats New Zealand impose these rules for to restrict re-identification, essentially. as the issue that Lisa raised. Yeah, I mean, it works for relatively small issues in the population, but not really, really small things. There's work that our colleagues have done with the Pacific population, showing how estimates of cancer in the Pacific population are essentially going to be really inaccurate because of that random rounding and the small number issues. You're running into the same stuff, essentially. So unfortunately, I would say it's an inherent issue that is not going to be overcome.
And I think that's where registries can be really useful. But I was going to say, I don't know, we've done some work with some pretty small populations.
Yes.
So I think that, I would say a couple of hundred is possible. It is possible to do some work.
Depends what you're doing with
it. does.
So what we did, we were sort of lucky enough. It's probably a strange word to use, but I think it was the ICD-10 code that enabled us to identify people with SMA. And so with this ICD-10 codes, you then can't publish so because it's such a small population. But we would do people like those people.
Yes.
So we'd look at like 99 people who are like the SMA person but weren't the SMA person, and then I think you could publish the differences because then your cohort was big enough. So I don't think you can publish individual things, but you can kind of look at trying to say, what's the difference of someone who's like this person but doesn't have a child with SMA versus this person with a child with SMA, or also someone suffering from SMA. And so when you do that, your cohorts are big enough, your numbers are big enough, you can actually publish more, but you don't lose that privacy that's so important. So I think it's that comparison of people like you that's the way to go. But you can't upload data sets because they're too small. So unless there's a way of identifying within the IDI, which is integrated data infrastructure in case people don't know what we're talking about, then I think you can do that study, but I don't think you can upload easily without breaching those privacy things. So which I think is really a concern because this is supposed to be all of New Zealand infrastructure. So I kind of feel like people with real disorders should miss out just because it's rare. But I'm not quite sure how to fight that one.
We should probably draw to a close. Thank you, everybody, for coming. I'm just going to hand over to Chris briefly.
It's my privilege to close this event, so I just want to say thanks again to Lisa and the Compass team for bringing it all together. Thanks, everybody, for coming along and contributing, and particularly all of the presenters. I think we found it a really useful day, and like all networking events in the rare disorder space, we come away having learned a lot more than what we brought into the session. So I certainly found it really useful, and will take a lot of new knowledge and insights away with me. So thank you very much for that, and it's now my special privilege to finish with a closing karakia. Kia tau ngā mana kātitanga āti mea naro, ki runga ki tēnā o tātou, kia mahia te hua makihiki, kia tō te kupu, tō te mana, toi te aroha, toi te reo Māori, kia tuturu ka whakamaua, kia tina, hui e, taike.